Thank you for giving us your time and attention today for Support After Abortion's monthly webinar for abortion healing providers. My name is Kylie Heap. I am honored to serve as the Executive Director for Support After Abortion. Last month, we had Amanda Hoff with us. She is our Relationship Development Specialist. She spoke about the power of collaboration together with guest speakers who provided examples and even some insights into relationship building that they felt advanced abortion healing within their communities. I want to encourage you to check out that webinar and other past webinars. They're located on our website under Healing Providers. And I especially want you to consider reaching out to Amanda. I want you to consider this because she will help you to learn how Support After Abortion might be able to collaborate with you. She's best reached at amanda@supportafterabortion.com. So today's topic has been heavy on our hearts at Support After Abortion for quite some time now, as our own experience connecting clients for after abortion care is highlighting a great need to be better educated in suicidal care. And for this conversation, we have brought a subject matter expert. She is certified as a clinical trauma professional and also certified in thanatology. That's the study of death and losses. It's scientific. Amy Vogel is a licensed mental health counselor. She's in private practice and she's working on her doctorate in counselor education and supervision. She specializes in traumatic grief and disenfranchised bereavement and has over 10 years of experience providing crisis counseling and grief support services. Her research and advocacy focus on effective suicide bereavement interventions. She has herself-led survivor support groups, and she serves on the boards for Suicide Prevention and Operation Solid 7. So we will turn our attention to Amy, who will educate us today as part one in a two-part series. We're going to scrape the surface this week with you and then invite you into a deeper dive for our part two webinar that will be a little bit longer and allow us to answer some questions for you that you might bring to the conversation. Without further ado, Amy.
For having me here today, especially during your lunchtime. I mean, who really wants to talk about suicide at lunchtime? Maybe me? I don't know. It's kind of a heavy topic, but it's so important, right? So whether you are here because you're curious, scared, or even maybe voluntold, I'm so glad you're here because this is a very, very important topic. So I'm going to share my screen. This is going to be very like lecture oriented. And if everyone can make sure that they mute themselves, that'll really help my concentration because I can have a squirrel brain and I'll be like, what was that? What's that noise? And then I'll get distracted, but I do very well at trying to keep myself managed, but that will help me even more. So let me go ahead and just share my screen. Okay, so we need to make this look a little bit nicer. Let's see, view. Slideshow. Does everybody see a little heart with some hands and it says suicide introduction? Good. Okay, wonderful. All right, now let's see if I can get the arrows to work. Oh, look at that. Oh my gosh, it's a good start so far. All right, so today our learning objectives are really to just identify, like, is suicide a problem? How big of a problem is it? So we're gonna really look at the scope of the problem, the factors, or you could say the risk factors of suicide, suicide risk in abortion, and assessments in planning to help you really understand, well, is suicide involved? How do I ask if suicide is involved? And then what do I do if they say yes? Because if you ask the question, you're going to get either probably a yes or a no or a thought. So trying to understand that question, like, making yourself ready to actually ask that question. All right. So suicide is a very complex public health issue. Yet, despite its complexity, suicide can be prevented. So just like there are warning signs and risk factors for other health crises, like let's say cardiac arrest, we can learn warning signs and risk factors that can help us prevent people from dying by suicide. So, as with other health issues, prevention can start early, far in advance of the problem, or prevention can occur closer to the time of the crisis. So, time, and that's like a big, like if you could put that in bold words, time can be a critical and life-saving measure. Typically, a life can be saved if you allow time for the person's suicide risk to subside or to get through that period of distress and get them to help, whether that be a professional, someone who knows how to do an intervention, or just you listening to them and connecting them to someone. So, to prevent suicide, we need to identify people who may be suicidal, as well as take an active role in connecting them to help before they take that action to end their lives. So, before we get really into suicide prevention and kind of our thoughts about it, let's kind of do a baseline of how we talk about suicide matters in that language that's preferred. So, we're going to go over some terminology that is used when we talk about suicide. It is important to model appropriate language so we do not perpetuate the stigma of suicide or mental health concerns. I think we're all aware that stigma is a large part of really a lot of the things we do, whether you're working with suicide, working with people who are afraid of their pregnancy, or even after abortion, all those things can make it, they're all stigmatized. They're all there's a lot of things, a lot of caveats that go through it. So I know language is so important in your guys' realm. It's just as important in the suicide world. So we really avoid using the phrase committed suicide. And this is probably the word that I hear the worst. And although I cringe inside and I'm like, oh Lord, I just take a step back and realize, this is just something that they don't understand or haven't been told. So the reason why we don't say committed suicide is it can have a negative connotation. And this is really coming back from suicide used to be a crime. It was something that someone committed to end their life. So that verbiage had been going on for a very long time, and the verbiage hadn't really changed, or actually the verbiage is still there. The laws have only changed since the mid 20th century. So we're talking, this has only been like 50 years that suicide has not been a crime. So instead, we encourage the phrases like died by suicide, ended their life, or something similar like that. I've also heard, I know the VA sometimes, the Veterans Administration, the military uses completed suicide. That's not my favorite, but it is one that you can use. If I had to rate them, I would say died by suicide is probably my favorite language to use about someone who took their life. So, education about suicide is critical for encouraging help seeking, raising awareness of risks in vulnerable populations, and advocating for new interventions and prevention strategies for those at risk. And when suicide is talked about safely and accurately, we can reduce that likelihood of its occurrence. And we want to change how society understands mental health and suicide, because when we open up and connect, we can save lives. We also changed some of the verbiage around people who have attempted suicide. So we always say like suicide attempt, things like that. We don't say like, or even I've even heard the words, they successfully suicided. This is not a math test. These are people's lives. We are not getting A's or, fail, or even a suicide attempt. I've heard they failed a suicide. We're just using more language appropriate words to help that stigma. Okay, let's move on. So, suicide statistics. Where are we with suicide? Is this really a problem in our world? What does the problem look like, even financially? So right now, currently, suicide is the 11th leading cause of death. And that seems really high. It was the 10th leading cause of death, and we are now the 11th leading cause of death. Our suicide rates lowered in 2020. So we only have data from 2021. So we're a little slow in getting our data. Over 700,000 people die by suicide worldwide each year. And in 2021, in the United States, 48,183 people died by suicide. Now, while that seems like a lot, it's underestimated. And the reason why it's underestimated is we are not taking into account the suicides that there could be accidental overdose that we don't really know if they were an accident or not. There just wasn't a suicide note tied to that. So it's definitely underreported. And that's kind of the hard thing is, especially with funding, trying to get more research into suicide and the suicidal behavior, that's really important. So if you break that down, all those suicides that we're losing each year, that's 132 suicides per day. And it's estimated that 1.7 million suicide attempts each year. And the socioeconomic costs and consequences, it costs $44 billion each year. Could you imagine what we could do with $44 billion? I could think of a few things. I mean, there's a lot of purses I could get, all kinds of different clothes. No, I'm just kidding. I would do it to something better than that. But okay. Now, I want you to realize that suicide rarely occurs outside of a mental health disorder. And while it is a major public health issue, suicide is taking more lives in the United States than homicide and natural disasters combined. Suicide also takes more lives than motor vehicle crashes. And a little more is for each suicide attempt, or for every suicide, so every person who dies by suicide, it's estimated that 25 others attempt, which is concerning because we have a lot of people who are attempting suicide that we don't know about and who could be alone and afraid to talk about their feelings and their thoughts about suicide because of the lack of public awareness and stigma. So let's look at some risk factors. Why do people take their own lives? Well, that is the golden question in suicide research that I'm not sure we will ever answer. And there is no single cause, but we're going to look at potential risk factors in 3 different categories. So the first category that we're going to look at is health factors, such as biological and psychological medical conditions, the most significant, which are mental health conditions. So like I said before, most people who die by suicide have an active mental health problem at the time of their death, whether that is diagnosed or not diagnosed. Depression is the most common mental health condition and the one that is closely and most associated with suicide. Now, bipolar is also shown to be a high risk, although the disorder is less common with suicide than depression. And because these conditions put a person at a greater risk for suicide, detecting the presence of a mental health condition is really important. So being able to identify their symptoms to see if they kind of match up with a mental health disorder. And, many people might not even realize that their distress has actually become a health problem. So it's very important to observe different kind of things that people might be doing. So not just what they're saying, but how they're reacting or even dressing, different things, something that's out of the ordinary of what is their norm. Serious or chronic health conditions can increase, especially when the person has a mental health issue. Chronic pain and serious head injuries have been found to increase suicide risk, especially if someone has had a traumatic brain injury. It can kind of change the structure of the brain and it can cause suicidal thoughts. Also, physical differences have been shown where the brains of people who die by suicide differ from those who die from other causes in terms of its structure and function, specifically in the areas related to stress response and impulse control. And I can tell you that that is true at a personal level. There's a particular psychiatrist in the United States. His name is Dr. Daniel Amen, and he does brain SPECT scans to identify mental health disorders. And he has his own clinic. Well, he has a lot of clinics, but his closest one to me is in Miami. And last year I got my brain scan to identify like what's going on in there. I attempted suicide 20 years ago, and I've had a lot of family members die by suicide. So this is something I'm very passionate about professionally and personally. And I learned that my brain is highly impulsive, which makes sense that the research is showing that impulsive brains can be a risk for suicide. All right, so now let's look at historical factors. So the second type is like his family history of suicide, a family history of mental health conditions, or a past trauma such as sexual abuse or combat stress. Also, if you have any, if you've done any research in epigenetics and how like generational trauma can affect people, all of these history type things is really important to understand to kind of give you some invitations on why suicide might be what's going on at the moment. Research has also found that a history of childhood abuse can contribute to suicide. And while most people who attempt suicide do not go on to die by suicide, previous suicide attempts are also considered a historical risk factor and do put the person at an increased risk. So it's very important to gather all of this data when you meet with a client. All right, so the last factor that we're going to kind of look at is the environmental factors that involve the circumstances of a person's life. So often there are aspects of a person's environment that can contribute to their overall level of risk. And we're going to look at some of the most common. One of those is having access to a way of killing oneself is referred to having access to lethal means. So this can include having access to a variety of things, such as firearms, drugs, and that can be prescription drugs too. We're not talking just about illegal drugs. A bridge, a car. People are very creative. So there are many, many different ways people can think about killing themselves or have killed themselves. So identifying a lethal mean is very important so we can be able to take that lethal mean away. Research has also shown that contagion, which is an exposure to another person's suicide or to graphic or very sensitization accounts of suicide, especially among those with risk, can increase another person's risk of suicide. So over glamorizing suicide can also increase that risk. Prolonged stress may include like harassment, bullying, relationship problems, legal problems, and unemployment. A stressful life event. This is probably what might be coming into your guys' offices. The event itself, and I think this is kind of anything with trauma, the actual event does not always cause trauma. It's how we respond to the event and what we have are resources to be able to respond to that particular event. For example, where I live, we had a hurricane and there were a lot of suicides just in our county. And so, but not everybody that went through the hurricane were thinking of suicide or died by suicide. Some people saw the hurricane as an exciting time to be able to help other people. So it's how we respond to a trauma, not necessarily the event itself. Okay, so now we've looked at health, historical, and environmental factors. But wouldn't it be nice if we actually had like a theory? Like my husband always tells me, Amy, my husband's very supportive. He has always been there for me when I have been suicidal or I've had thoughts of suicide. It's something that just doesn't go away for me. It's something that I've learned to live with. And this, I think what we're going to talk about next, and this is the interpersonal theory of suicide. And this gets a little research heavy, but I'm going to make it as easy and comfortable to talk about as possible. But I think this helps answer the question like, wow, I can never even imagine taking my own life. Why would someone want to kill themselves? And my husband always tells me, I've never, ever had that thought. And you might be sitting here today thinking, I can't even go there. I would never, ever think that. And so basically, I want to explain this theory to you to kind of help you understand how maybe somebody can actually get to that point. I've grown up on the outside. Let's just use Instagram. Okay, I don't even post on Instagram, but let's just use like that Instagram life, right? I look like I have a great family. I come from a very good family. I never had anything that I never had to worry about food. I never had to worry about getting things. I had parents who are still together today. Everything on the outside looked really good. I had a good job. I went to college, all these things that, appear to be like a good person. However, I have been struggling with suicidal thoughts since I was 15 years old. And that's like the dark side, right? And I want to help you understand that dark side. It's not something that I like to think about. It's not something that I'm like, yay, I want to think about suicide today. It's just something the way my brain thinks, but I'm able to cope with it. Okay. So if you kind of think of diabetes, you cope with it by eating, exercise, your insulin levels. With my suicidal thoughts, I cope with it with, doing a funny puzzle, exercising, taking my medication, doing all these different things, going to therapy. So it's very similar to like what people will say is a health issue, even though we have just identified suicide is a health issue. So here's a theory. So this was actually a really cool theory developed by a psychologist and psychology professor named Dr. Thomas Joyner, and he still teaches today at Florida State University. And his father died by suicide, and he's basically kind of done the same thing that I have done. This is like his purpose in life, to be able to help people understand about suicide and to research it. So this theory is called the interpersonal theory of suicide, and it suggests that two important feelings can make someone more likely to consider suicide. And the first feeling is when someone feels like they just don't belong or fit in anywhere, which is called thwarted belongingness. The second feeling is when someone feels like they are a burden to others, and this is known as a perceived burdensomeness. Now, this is where it gets a little interesting. The theory also talks about another aspect called acquired capability for suicide. And this means that over time, some individuals may become more capable of actually engaging in suicidal behavior, like attempting suicide. It's like a combination of feeling disconnected and a burdensome, along with the ability to act on those feelings. So example, that impulsive brain. So this theory suggests that it's not just about wanting to die, but also about having the means and ability to do so. By understanding these factors, we can better identify and help those at risk at suicide. It emphasizes the importance of social connections and support in preventing suicide. So what the interpersonal theory of suicide gives us is a framework to understand why some individuals may be more vulnerable to suicidal thoughts and behaviors. So by addressing these feelings of isolation, burdensomeness, and building support systems, we can work towards preventing suicide and supporting those in need. So I want to give you an example. I have friends. A lot of people have friends, but I just recently went on a girls' weekend. There was like 11 of us. That's a lot of girls in 2 days in a weekend it was a like a hotel suite. There's like this new little fancy hotel over here in Punta Gorda, Florida, in the middle of nowhere. It's this gigantic, really nice hotel. I was so anxious. I was so anxious because I, for some reason, have this perceived like feeling of not being able to belong. So I had an increased anxiety of, oh my gosh, do I belong? Are these people really my friends? Like it was like a revolving door. And I just like kept like hitting my head on this door. Like, do they like me? Am I weird? Do I say things weird? Oh, are they going to think that's strange? Like all these things that go through my brain. And then I just feel like I'm a burden. I'm a pain in the butt. I get anxious. I say things out loud that I'm like, oh, I forgot I was in public. All these different things. So if you look at that like first circle where it says those who desire suicide, I was having this like failed belongingness. I didn't feel like I belonged to this group. Perceived burdensomeness. I tend to feel like I'm a burden on everyone. Okay. These are thoughts that I have in my head every single day. So it's exhausting because you have to like retrain your brain at all times. So I've been feeling like this for like a week up to the actual event, right? So now we have the event of hanging out with all these girls, feeling like, am I going to be judged? Oh my gosh, does my butt look fat? I mean, who really cares? No one should really care. These are all things that I'm making up in my head. Now, if we add in those who are capable of suicide, now remember, we just learned that people who have attempted suicide, that's another risk, right? So I've already attempted suicide. I've had family members who have attempted suicide. Now we know that Amy has an impulsive brain. So we're kind of creating this perfect storm. All right. So what happened when Amy got home after all of this stress that she made up all in her brain? Amy was tired and Amy cried and kind of had a mental breakdown on Sunday. I'm a mental health professional. I know what I'm doing. But remember, remember when we talked about the insulin, people who are diabetics? It's like, okay, my cousin has juvenile diabetes. If he drinks or if he eats really bad things, he's going to like suffer from those consequences. I suffered from those consequences. I will tell you 120% I was suicidal, but that does not mean that I was going to kill myself because I was able to get my support system. I was able to get that time away from the means. Like my family knows that my means are pills or like any kind of knives. So being able to share that with my family so they know how to keep help keep me safe in those times. So I was able to separate that time from my means, and I'm here today. All good with you guys. So I like to use myself sometimes because it keeps it real. And I think it helps really help you understand like people who do think of suicide or struggle with suicidal ideation can be very successful people. All right. Okay. Suicidal ideation. Oh boy. So there's different levels. I'm not sure if anybody knew that, but there's just like, okay, so if we look at autism, there's autism spectrum. There's like a suicidal ideation spectrum. For example, with autism, we have people who are unfortunately nonverbal, who have to live in homes because they're not able to take care of themselves. And then we have somebody who has autism like Elon Musk, who's extremely successful, is a billionaire, and has been able to do life pretty well. So just like with anything else, there's a spectrum with suicide. All right. So this one that we're going through here was developed by the same people who developed the scale on what we could use with people who are suicidal that we're going to talk about after this. But I want you to really understand these levels, because when someone says that they're thinking about suicide, that does not mean that they are going to kill themselves right then and there. You have time. If you're talking to them, that is time. You keep talking to them. Okay. So I want to help dissect these thoughts to kind of ease your comfort, because talking to them is just keeping that time away from their means. Okay. So let's go over some of these levels. So we're going to start on the right. It goes from the right, and then like the little red is all the way like the worst. That would be the suicide attempt. So suicidal thoughts, this little box on the right, this is when people wish to be dead. I'm sure somebody has always said, oh my gosh, I wish I could just die right now. It's kind of funny because after you lose people to suicide, people are like, oh my gosh, I'm so sorry I said that. Like, it's like you're the weird person in the room, but it's just funny. But suicidal thoughts, that first one, these are when people wish they were dead. And this level indicates a general desire to not be alive anymore. It may involve thoughts of wanting life to end, but without specific plans or intent to actually make that happen. Okay, so that's your lowest level of suicidal thoughts. Now we're going to move up. These are still suicidal thoughts, but without a plan or intent. So we can call this non-specific, active suicidal thoughts. And at this level, the individual experiences more active thoughts about suicide. And these thoughts are not focused on a particular method or in plan, but they do involve a stronger desire to end one's life. So that's that part. Sorry, these little levels are so big and take up the thing. I got to move my little bar of people. I've got to move you guys around. All right, so next up we have suicidal intent, and that's the box in the middle where it says intends to attempt suicide, but no specific plan. So this is suicidal thoughts with methods. So, and that's with an S on methods. So this level involves thoughts of suicide along with considering specific methods or ways to carry out the act. So the individual may be thinking about how they could harm themselves, but they haven't really thought, this is my plan. This is my intent. This is my, remember we use those words, lethal means. Okay. Now, we go into the next one here, suicidal with plan and intent. Okay, so this person has a clear intention or purpose to end their life. Okay, so they are actively planning or preparing to carry out a suicide attempt, indicating a higher level of risk. And then we go to the highest of the spectrum, and that is your suicide attempts. And this is the most severe of suicidal ideation. It includes not only the intent to die by suicide, but also a detailed plan of how and when to do it. Individuals at this level are the highest risk of attempting suicide. So this is where you would either need to call 911 or have someone who can do a suicide intervention, call the suicide hotline, something along those lines. And not every suicidal person needs to have 911 called on them. It's when they're not really listening or working with you and they have that plan, they have that means, and they're basically calling you to either, for some reason, let someone know or get some sort of validation like it's okay. And that's when you need to make sure. Now, definitely, like if you have someone that comes into your building with suicidal thoughts and they have the intent and the plan and the means with them, for example, if you find out that they have a gun in the room with you, you need to leave that room immediately. You need to stop trying to make conversation with them. You need to leave. You need to call 911 because we don't need more than we don't need the helper to accidentally get caught in the crossfire, because that can be very, very dangerous. We make sure everyone's safe. All right. Oh, I think I get my little mouse. Oh, there we go. All righty. Okay. So we've learned a little bit about risk factors that can increase these thoughts of suicide. We've learned that brains can be more towards thinking about suicide. We've learned the spectrum of suicidal ideation. So what if I meet someone who I believe is suicidal? What do I do? That's a really good question. And so there has been a scale that has been created and very, very widely used. So this scale that I am going to explain to you today is being used by the National Suicide Prevention Line. It's being used in emergency departments. It's being used with the military, recommended by the VA and our government. It is recommended by the research for suicidal ideation, suicide attempts, that kind of world. This is one that I use, very common. And I want you to think of this tool as a compass, and it's guiding the helper in understanding the depths of someone's thoughts and feelings when it comes to suicide. So those thoughts and feelings, that can go back to that interpersonal theory of suicide, right? So that's why I wanted you guys to get a real good foundation to really understand this piece of paper. Because while this is a piece of paper, we're dealing with a person, and this is not a checklist. It might look like a checklist, but it's not a checklist, okay? So it's called the Columbia Suicide Severity Rating Scale, or most commonly it's called the CSSRS, or suicide list. I just call it the suicide paper, actually. You can treat it like a map that helps you navigate the complexity of suicidal ideation and behavior. So I want you to picture this scale as a ladder with different rungs, each representing a level of severity in suicidal thoughts. Remember, suicidal thought spectrum. I think someone is, yep, there we go. They're on mute now. Thank you. Okay, so we have the bottom rung. We have the wish to be dead, a general feeling of not wanting to be alive. As we climb higher, we encounter non-specific active suicidal thoughts, where the desire to end one's life becomes more pronounced. Further up this ladder, we reach suicidal thoughts with methods, indicating thoughts about how one could harm themselves. So we're moving even higher, and we find suicidal intent, where the individual is actively planning to end their life. And at the very top, we have suicidal intent with plan. And again, this is the most critical level, where a detailed plan for suicide is in place. But this particular instrument or rating scale does not stop there. It also delves into the intensity of these thoughts. It looks at how often these thoughts occur, how long they last, whether they can be controlled, what might prevent the person from acting on them, and why these thoughts are present. So using this scale is like unraveling a person's story, understanding their struggles, and identifying the level of risk they may be facing. By assessing both the severity and the intensity of suicidal ideation, healthcare providers can offer the right support and intervention to those in need, potentially saving lives and providing hope in those times of darkness. So basically, this is not just a tool, but if you think of it as like a beacon of light in the journey on suicide prevention, it's guiding us to a better understanding of individuals' thoughts and emotions, and paving the way for compassionate care and support. All right. So I want to go through this scale kind of line by line, because I feel like it's easier if you just go through it and be able to identify it. Because the first thing, if you start utilizing this scale, you do not want to say, Have you wished you were dead or wished you could go to sleep and not wake up? And then if they say yes or no, you check it off. Personal experience, when one time I was suicidal and my husband took me to, we were living in Indianapolis, Indiana at the time. He took me to it was like a crisis center, I guess. And all I remember is this lady with a checklist with her, she had like a paper, she had her pencil, and she didn't even look at me. She looked at the paper and she would ask the question and she would just make a check mark. And the reason why I'm telling you this is because I did not feel validated there. I did not feel safe. I did not feel heard. Most importantly, I did not feel like they were understanding what I was trying to say. And when people are suicidal, I want you to think of probably the most pain you've ever had in your life. I would say I would say most people would think of childbirth, but I took the drugs, so I didn't feel a thing. It was fine. So I'm trying to think of something that was very painful. You know, paper cuts are the most annoying thing though, because they're little and they're tiny and it's like they're always on like other things. But I want you to think of the most painful thing. And I want you to think in that moment, do you think that you are able to give detailed directions for someone to come to your house who's never been there before? Probably not. So it's very hard for someone who is in a crisis situation. So we're talking about that suicide level is really close to like almost that red, right? That's where I was at. And her words just came off as not they felt judgy. They felt like she didn't want to be there. She was just collecting a paycheck and I was just the next person on her list to go. So what I really want people to understand when they use this scale is to make it a little more like a conversation. And when you are calm and you feel comfortable about it, then you're able to kind of model that behavior to kind of help that person who's in that very high suicidal ideation to relax and calm down as well. You can get into the neuroanatomy of stress responses and understand like the difference between your sympathetic and parasympathetic system. Your brain is literally in fight flight mode. All the different, I think there's like fawn now, there's all kinds of different ones. And what we need is that brain to relax. So the more you make a conversation and a caring voice and just your presence makes your body relax. So also, prior to using this scale, that's very important, is really identifying your personal attitudes and biases with suicide. Now, this is a very personal thing. So I would almost suggest, I don't know if anybody's ever done a brain dump before, but putting like 3 minutes on a timer on your phone and just writing all the things you think about suicide. It can be it makes me angry. Why would people do it? That's selfish. You can think of the nastiest things. But the important thing is to get it all out. You can burn it, you can trash it, you can shred it when you're done. But it's very important to sit in your attitudes and your biases, your personal ones about suicide, because you want to be fully present for this person. Because it's not necessarily the suicide that's really going on here. It's how we're responding to a particular trauma or event. For example, when I became suicide on Sunday, it wasn't a particular thing. It was that interpersonal theory of suicide. It was all these thoughts that I built up. It was all these burdens that I built up. And then these historical factors of things that have happened in my family with suicide. All those put together. Okay. So when people are coming in who have had an abortion or they are so fearful of an unexpected pregnancy, it's not the actual event, it's how they're responding to the event. And it's not the suicide. And when you hear the word suicide, it can be scary. And that's why I think it'd be very important to really explore those personal biases and your attitudes and how you feel about that, because then you're able to kind of get past that, get that out of your head and be able to understand it more so you can help people be able to cope through these responses to the events that they're going through. So first question 1 and 2, have you wished you were dead or wished you could go to sleep or not waking up? You can make yourself familiar with that question. You can even say it like that. You don't have to memorize it, but make it you. That's not me. I would probably say something like, have you ever felt like you wanted to die? Or have you ever like thought, oh my gosh, it'd be so good to go to sleep and never wake up? Like that's how I would say it, but you probably won't say it like that. You have to say it how you would say it. And then you have to ask that really hard question. Hey, are you thinking about killing yourself? And I want you to notice this is in the past month. If you see on the top right, these are thoughts in the past month. Okay. And then go on to that next question. So if yes to question 2, then you ask the next questions. If they say no, then go exactly to question 6. Have you ever done anything, started to do anything, or prepared to do anything to end your life? So, and it even has little examples for you. And I think we're going to do a training next month that goes much deeper into this. So I'm not going to waste much more time on this, but we will do a deep dive into this and maybe even explore those attitudes and biases. I don't know if you've ever taken like a multicultural class. That's the first thing we do. What are our attitudes and thoughts about multiculturalism? To learn behavior. So we got to figure this out. And once we get past those kind of like icky thoughts, then we can get down to like, this is a person. This is a person who is just feeling really lost. And the fact that they're telling you that they're suicidal, they may have never told anyone in their life that. And that might seem really heavy, but what it tells me is you were open enough and they saw enough in you that you were a safe person to be able to talk about those big things. Okay. So whether they are suicidal or not, I think it's very important to be able to create a safety plan with a client. Or, I've always found it interesting after I go to a suicide training, it's like something pops up, like I'll have a text message and it's like, I have a friend who's thinking about suicide. Do you know anything about that? It always comes up. So having this is called the Stanley Brown Safety Plan. This is my absolute favorite safety plan for people who are suicidal. And the reason why is because it goes through like all of those historical, like all those risk factors that we talked about earlier. So the first step is identifying warning signs. A lot of times people who are suicidal might not even really realize what their warning signs are. So if they're able to identify their warning signs, then it's like a light bulb. Oh, these are what I do before I start thinking about suicide. I need to start working on my coping. So for example, warning signs can be non-suicidal self-injury, like cutting. It can be really, really negative self-talk. It's going to be different for everybody. And that's why it's really important to be able to ask that person. And I would suggest getting like at least 3 warning signs from your person that you're working with for them to write it down. Step 2 are internal coping strategies. So you can help the client identify what they can do to kind of get their mind off their problems. And this is without contacting another person. So these are things that they can do internally. So listen to music. It could be playing a game on their phone. It can be, I love puzzles. It can be drawing. It can be whatever they want. So a lot of times I'll just give like a couple examples, but then I help them learn because I mean, I don't think everybody in the world likes to do puzzles. I hate playing games on the phone. I don't like it. So that wouldn't be good for me. So kind of give them a couple suggestions if they have a hard time, but really making it about them. And then step 3 are people in social settings that provide distraction. So for example, these are not people that you can ask for help in a crisis. That's number 4. These are people that can just kind of like, you're like, I feel much more safer around. I can go to this place and feel safe. It's just a distraction, but they're not going to like really do like a deep dive intervention with me. Step 4 are people who can do those things. So for example, my mom is a good one for step 4. I have a close friend who's also a counselor that I can call. I also have my husband. So those are people like that can provide distraction, or I'm sorry, help, that you can actually call for help during crisis. And then step 5 is just those professionals or agencies that you can contact. So you can ask them, do you have a counselor that you can write down here? If not, you can give them some referrals or like have them show them about Psychology Today, emergency contact 911, the non-emergency line. There's 988, which is the crisis line. There's the text line. I think it's text. I think you can text whatever you want, but I think it's like text home to 741 741. And then what are step 6? Make your environment safety. So for example, say someone does their lethal mean is a gun. So how can we keep that gun safe? Well, we could get like, there's like locks for your guns, like the actual gun locks, and then you can put it in a safe. Or you can say, who can take that gun from you and put it in their safe? Or, because it is very exhausting to be suicidal, and it's hard to make a lot of decisions. So you can actually take the bullets, put it in one place, take the gun and the other thing, put it in separate parts all around the house. And you can do that with pills, all kinds of things. So I love this safety Brown plan because it's very robust and it captures everything to keep someone safe. All right. Okay, so in conclusion, I want to emphasize the crucial role that we can all play in suicide prevention. And suicide is a serious public health issue that affects individuals, families, and communities all across the globe. However, it's important to remember that suicide can be prevented through awareness, compassion, and timely intervention. So throughout this presentation, we have explored the scope of the problem, the factors that contribute to suicidal desire and capability, and the tools available for assessing and managing suicide risk. We've also discussed the significance of using appropriate, non-stigmatizing language when we talk about suicide to create a supportive environment. One of the most important things we can do to help prevent suicide is to be there for others and actively listen to their concerns. When someone is experiencing suicidal thoughts, they might feel isolated, helpless, and alone. And by offering a non-judgmental and supportive presence, we can help them feel heard, validated, and connected. And active listening involves giving that person your full attention and asking those important questions. Are you thinking about suicide? And not being scared if they say yes. And just showing them empathy and understanding. And in addition to being there for others, it's crucial to know the resources available for suicide prevention. So that means including helpline numbers, websites, local support services. Familiarize yourselves with these resources and provide valuable information and support to these people in need. So I want to leave you with a message of hope. Suicide is preventable and help is available. And by working together, we can create a world where everyone feels supported, valued, and connected. And I encourage each of you to continue learning about suicide prevention because this is very introductory. Suicide 101, to be proactive in supporting mental health and well-being and being there for others in times of need. Because remember, every life is precious. And every person deserves the right to be heard and supported. And together we can make that difference in the fight against suicide. So that's all I have for you guys today. And I'm going to stop sharing my screen.
Well,
Well, Amy, thank you so much for this amazing presentation today. It has been a hot topic, I know, on our support line, and as we've connected with more providers, it is becoming more part of our process. So we are very excited for your deeper dive.